Hey everyone, and welcome. If you're heading into your pediatric rotation, this is definitely for you. Today, we're going to dive into some super high-yield clinical info on pediatric cardiology. Think of it as the absolute must-knows, how a healthy kid's heart is supposed to work, the key things to look for in your assessment, and the big acquired diseases you're actually going to see on the floor. And just a heads up, we're setting congenital defects aside for today. Why? So we can get absolutely rock solid on these core concepts first.
All right, let's jump right in with a little scenario. Picture this. You're on your shift and a 4-year-old comes in. They've got this persistent high fever, a rash spreading across their torso, and their parents say they have a strawberry tongue. So, what's your nursing brain doing right now? What alarm bells are going off? What serious heart condition should be lighting up your radar? Just hang on to that thought for a bit. We're going to circle back and solve this case together.
But before we can put on our detective hats, we have to know what a normal crime scene looks like, right? You can't figure out what's broken if you don't know how it's supposed to work in the first place. So let's start with the basics and review the fundamentals of the heart's incredible journey.
So, the heart, it's really just two pumps working together in perfect harmony. The right side's entire job is to handle the blue, deoxygenated blood. The right atrium acts like a receiving dock, collecting all that used-up blood from the body. Then the right ventricle gives it a big push over to the lungs for a pit stop to get more oxygen. Then the left side takes over. It gets that fresh, bright red oxygenated blood from the lungs. The left atrium collects it, and then the left ventricle, which is the real workhorse of the heart, pumps it out with tremendous force to fuel the entire body. A super simple way to remember it: right side goes to the lungs, left side goes to the body.
So let's follow a single drop of blood on its little trip, okay? It comes back from the body, it's tired, it's out of oxygen. First stop, the right atrium. From there, it drops down into the right ventricle, which contracts and whoosh, pumps it straight to the lungs for a fill-up. Once it's loaded up with fresh O2, it heads back to the heart, but this time it enters the left atrium. Then it drops into that mighty left ventricle, which gives it the final, massive push out through the aorta to the rest of the body. It's just a perfect, continuous loop.
You know when you put your stethoscope on a little one's chest and you hear that classic lub-dub, lub-dub? What are you actually hearing? It's not the heart muscle squeezing. Nope. You are literally hearing doors slam shut. The first sound, S1, the lub, that's the sound of the mitral and tricuspid valves closing. The second sound, S2, the dub, that's the next set of doors, the aortic and pulmonic valves, snapping shut right after. So just remember, you're not hearing the rooms, you're hearing the doors between the rooms. It's all about the valves.
Okay, so now we know what a healthy heart should sound like. Let's get into the good stuff, how to find the clues when something is going wrong. This is where you, the nurse, become the lead detective at the bedside. Your investigation starts with asking the right questions. You gotta dig a little. Ask about family history. Are there any genetic issues floating around in the family tree? What about the pregnancy? Any infections or weird exposures? Was the baby born early? And then, for the kiddos themselves, and this is huge, how are they eating? A baby whose heart is working overtime just upon blood doesn't have a lot of energy left for eating and growing. And here's a pro tip: don't get hung up on chest pain. While it's a major red flag in adults, it's actually pretty rare in kids with cardiac problems.
Now it's time for your hands-on exam. You're going to use your eyes, your hands, your ears. First, check their height and weight. Is this child failing to thrive? Look closely at their fingers and toes. Do you see any clubbing? You know, where the nail beds get all puffy and round. That's a classic sign of long-term low oxygen. Watch them breathe, especially when they eat. Is it a struggle for them? Then check your basics: pulses, cap refill, any puffiness or edema. Look at their skin color. Is it pale, kind of blotchy, or even bluish? And of course, listen with your stethoscope for any murmurs, that whooshing sound that tells your blood flow is turbulent, not smooth. Okay, let's switch gears. Now we're going to talk about heart problems that kids aren't born with, but that they can develop later on, usually after an infection. These are the acquired heart diseases, and there are two big ones you absolutely have to know.
The two big names you need to remember are rheumatic heart disease and Kawasaki disease. Think of it like this. Rheumatic heart disease is the one we know. We know the culprit. It's a nasty complication from an untreated Group A strep infection. The body's immune system basically gets confused and attacks its own heart valves. Kawasaki disease, on the other hand, that one's a mystery. We know it's the #1 cause of acquired heart disease in kids in the developed world, but we still don't know the exact bug that causes it. Kind of wild, right? This timeline right here shows you exactly why we are so intense about treating strep throat. It starts simple. A kid gets strep, but if it goes untreated, about 3 weeks later, the body's immune system can just go completely haywire. That's called rheumatic fever. And the really scary part is that even after the fever goes away, the damage to the heart valves can happen silently, over years, leading to permanent, lifelong problems.
Okay, so let's zoom in on Kawasaki. For your exams, for the NCLEX, for real life, there is a magic number you have to remember, and that number is 4. To diagnose Kawasaki, a child needs to have a high fever for at least 5 days, plus 4 out of the 5 classic clinical signs. So what are those 5 signs? Well, remember our kid from the very beginning of this explainer? Here is your answer. You're looking for a rash, enlarged lymph nodes in the neck, and conjunctivitis. And the key here is that it's red eyes with no goopy discharge. Then you look for changes in the mouth, like bright red, cracked lips, and that classic strawberry tongue. And finally, you look for redness and swelling in the hands and feet. So a persistent high fever with any 4 of those signs should have you screaming Kawasaki.
And this is exactly why catching it early is so critical. You can't wait on this. Why? Because Kawasaki is a vasculitis. It causes inflammation of all the blood vessels. And when it attacks the coronary arteries, the ones that feed the heart muscle itself, it can cause them to weaken and bulge out, forming an aneurysm. An aneurysm in a coronary artery can lead to a heart attack in a child. That's why we hit it hard and fast with high-dose aspirin and IVIG. The goal is to cool down that systemic inflammation and protect those coronary arteries.
All right, our last section. We have to talk about what happens when things go really, really wrong. This is the end game for a lot of severe cardiac conditions, the critical complications of heart failure and shock. So, what is congestive heart failure, or CHF? The absolute simplest way to think about it is pump failure. For whatever reason, the heart just can't pump strong enough to get that oxygen-rich blood out to the rest of the body. The body is demanding fuel, and the heart just can't keep up with the supply.
And heart failure isn't just one thing. It really depends on which side of the pump is failing. Think of it like a traffic jam. If the right side of the pump fails, blood backs up into the body. You'll see systemic edema, puffy hands, feet, even a puffy face. But if the left side of the pump fails, the traffic jam backs up into the lungs. This causes pulmonary congestion, and when you listen, you'll hear those wet, crackly breath sounds. Easy way to remember. Right-sided failure backs into the rest of the body. Left-sided failure backs into the lungs.
And that brings us to shock. Let me be clear. This is a code blue, life or death emergency. Shock is when the body's entire circulatory system is collapsing. Blood isn't getting to the tissues, which means oxygen isn't getting to the cells. It's a major cause of death in children worldwide, and your ability to recognize it fast is one of the most important things you will ever do.
Okay, shock can feel really complicated, but you can break it down into 3 main types. The easiest way I've found to remember it is to think about what's failing. Is it a problem with the volume, the pump, or the pipes? Hypovolemic shock is a volume problem, not enough fluid in the system, usually from severe dehydration or bleeding. Cardiogenic shock is a pump problem. The heart muscle itself is damaged and can't squeeze effectively. Distributive shock is a pipes problem. The blood vessels get all leaky and fluid shifts out. The classic cause here is overwhelming sepsis. So just remember, volume, pump, or pipes.
When a child is in shock, every single second counts. You have to move. First, you can put them in the Trendelenburg position, feet up, head down, to use gravity to get blood back to the vital organs. Then, you address the cause. You're pushing IV fluids or blood for a volume problem, or you're starting vasopressors for a pump problem. And no matter what type of shock it is, you are giving supplemental oxygen to make every single red blood cell count.
So we'll end on this thought. It's not always going to be the loud, dramatic code situation. A lot of times it's a subtle change. A baby who is just a little too tired to finish a bottle. A new, faint murmur you've never heard before. Skin that just looks a little off. As the nurse, you are right there at the bedside. You are the eyes and ears on the front line. You are the one who is going to see that subtle change first. So the question is, after this review, what are you going to be looking for? And how quickly will you act? Because that is what makes all the difference.